Hi, everyone. For this lecture, we're going to dive into acid-base disturbances, and we are going to just review conceptually acid-base disturbances. We will talk about ABG analysis in class, okay? Because I feel like that's something that needs to be discussed in class. So let me get my PowerPoint up on the screen. Hold on, I'm just trying to get a better view here. Okay. I have to stop. Someday I will get easier at this. Okay. So that's what we're sharing. Okay, so the PowerPoint's up there. So here you can see that the information for this lecture comes from ATI chapter 46 and Brunner and Starth chapter 10. Skipped a slide. So we're going to talk about acid-base disturbances, understanding that the pH of blood is 7.4, and if it becomes lower than 7.35, it's acidotic, and if it becomes greater than 7.45, it's alkalotic. So acid-base disorders are conditions that occur when the levels of hydrogen ions or bicarbonate ions in the blood change, which alters the pH of the blood. So hydrogen is acidic and bicarb is alkalotic. Acid-base disturbances are crucial in clinical practice, particularly in critical care settings or emergency departments, and I know a lot of you want to go there. Identifying specific imbalances aids in understanding the underlying causes and developing treatment plans. So, a plasma pH will indicate that the higher hydrogen ion concentrations are reflecting can either reflect blood acidity or alkalinity, which is what I said. So a normal pH range, because we can fluctuate a bit, is 7.35 to 7.45. It's very important for you to know those numbers. A higher concentration of hydrogen will equal more acidic and a lower pH. A lower concentration is more alkaline and a higher pH. So the body is this amazing system which has homeostatic mechanisms. So we have the ability to regulate that pH. So the buffer systems prevent drastic pH changes by removing and releasing hydrogen. A major extracellular buffer is the bicarbonate system. So that's the HCO3. A normal ratio of HCO3 to H2CO3 is 20 to 1. Changes in this ratio will lead to pH alterations. And then we have CO2 and carbonic acid. CO2 dissolves in water to form carbonic acid, so that would be H2CO3. And increased CO2 equals increased carbonic acid, which will alter the pH. A decreased CO2 is going to decrease that carbonic acid and alter the pH. And then we have some regulatory systems. So the kidneys regulate bicarb levels by regenerating and reabsorbing bicarb ions. So they have those compensatory roles. On this slide, it should say respiratory acidosis, metabolic acidosis, and respiratory metabolic alkalosis. I missed the respiratory part. But for respiratory acidosis and metabolic acidosis, we need to excrete that hydrogen ions and conserve our bicarb. With respiratory and metabolic alkalosis, we want to retain that hydrogen and excrete the bicarb because you have to understand that we need enough acid and enough bicarb to balance out the pH. So if we have too much bicarb, we need more acid. If we have too much acid, we need more bicarb. Slow compensation is hours to days. And then similarly with the lungs, it regulates CO2 levels by ventilation adjustments. Increased PaCO2 stimulates respiration, and the influence of PaO2 is less significant than PaCO2. So for metabolic acidosis, we have an increased respiratory rate, and a metabolic alkalosis, we have a decreased respiratory rate. So understanding these acid base imbalances requires knowledge of the bicarb buffer and chemical reactions. And then we have the acid base balance and the chemical reaction. So again, the chemical equation here is carbon dioxide plus water equals carbonic acid. Carbonic acid dissociates into hydrogen and bicarb. The major organs in acid base balance we know are lungs, which regulate the CO2 levels, and kidneys, which excrete and reabsorb ions to balance that pH. So then we have ABGs. ABGs will allow us to see what the blood pH is, what that partial pressure of CO2 is, what that partial pressure of O2 is, and what that bicarb level is. These numbers are what we need to diagnose acid-base imbalances. Oxygen saturation is measured by pulse oximetry, and the normal range should be 95 to 100. But we know from other as we've advanced our education, that a normal range is patient specific. So, hypoventilation plays a role in acid base imbalances because it is a slowed breathing rate. So, let's think why we would need a slow breathing rate. If we know that we blow off CO2, which is essentially acidic, then we know that if we slow our breathing rate, we're going to increase that CO2 retention. So we're going to save some of that acid. So that might make you think that we might be high in bicarb. So the effect is we're going to increase that CO2 retention. A normal PaCO2 range is 35 to 45. It can exceed 45 during hypoventilation. Increased CO2 shifts the equation to the right, producing more hydrogen and causing acidosis. So an acidotic pH is going to be less than 7.35. So now let's talk about hyperventilation. Hyperventilation is that increased breathing rate. So we're blowing off a lot of CO2. So we're going to lose that CO2, and then decreased CO2 shifts the equation to the left, reducing hydrogen and causing alkalosis. So alkalosis pH is anything greater than 7.45. And then we have compensatory mechanisms where we have that increased hydrogen ions could be associated with lactic acid accumulation, diabetic ketoacidosis, toxicity. And then we could have equilibrium shifts left, increasing the CO2 for elimination. The lungs would compensate by increasing breathing rate to expel that CO2. And then if we have decreased hydrogen ions, the equilibrium is going to shift to the right, using up the CO2 to generate more hydrogen. Lungs will start to slow their breathing because we want to retain that CO2, that acid, to increase those hydrogen levels. And then we have acute and chronic metabolic acidosis. So we're going to get into metabolic acidosis and alkalosis and respiratory acidosis and alkalosis. So metabolic acidosis is we have a bicarb deficit. So acidosis, you can look at it as an increase in hydrogen. Because I look at when I'm understanding acid-base balances, I know that CO2 is an acid and bicarb is the base. Okay. So we know that if we have an acidosis, we have an increase in hydrogen and a decrease in bicarb. Okay. So metabolic acidosis is characterized by low blood pH, increased hydrogen concentration, and low plasma bicarb. It can result from a gain of hydrogen ions and a loss of bicarb ions. That just makes sense. And forms of metabolic acidosis are high anion gap metabolic acidosis and normal anion gap metabolic acidosis. So let's talk about anion gap. Uh, the difference between measured cations, positively charged, and anions are negatively charged. Okay, so we have the cations and the negatively and the anions, and what the difference is going to be our anion gap. A normal range without potassium is 8 to 12, and with potassium is 12 to 16. A high anion gap indicates excessive accumulation of unmeasured anions. So, valuing an anion gap with potassium means calculating the anion gap by including the potassium ion concentration in the equation, while valuing an anion gap without potassium means calculating it without considering potassium. Essentially, we would only use sodium chloride and bicarb levels. The latter is more common practice because potassium levels usually have a negligible impact on the overall calculation due to their relatively low concentration in the blood. So, a normal anion gap metabolic acidosis is going to be that direct loss of bicarb. So, examples of that could be diarrhea, intestinal fistulas, diuretics, early renal insufficiency, excessive chloride administration, and high anion gap with metabolic acidosis would be that excessive accumulation of acids. So, lactic acidosis, salicylate poisoning, renal failure, DKA, where high amounts of hydrogen neutralize the bicarb, increasing the anion gap. So, this picture right here is all of the reasons why we could have an anion gap. And I included these pictures from the internet because I think it really helps. So, clinical manifestations of metabolic acidosis. Symptoms are going to vary with severity. We could have a headache, confusion, drowsiness, increased respiratory rate and depth because we want to blow off that acid, nausea and vomiting, peripheral vasodilation, and decreased cardiac output. Severe cases we want are going to be decreased blood pressure, cold, clammy skin, arrhythmias, and shock. So chronic metabolic acidosis often results from chronic kidney disease. So pay attention to the history. Assessment and diagnostic findings. So we'll use ABG measurements, a low bicarb and a low blood pH. We'll have elevated hydrogen leads to potassium shift into the bloodstream, resulting in hyperkalemia. We could have ECG monitoring because we want to make sure that we monitor for an arrhythmia risk with the potassium changes. And then our lungs are going to compensate by hyperventilating to reduce CO2 levels and decrease hydrogen concentration. And how do we manage these patients? I copied the same thing. The slide is wrong. So medical management for these patients is treat the underlying cause. That's what it's going to be. Treat the underlying cause, and you will balance out that potassium. I mean, you'll balance out the acid base deficit. If we have high potassium that shifts into the bloodstream, we want to dilute that potassium with a little bit of fluids. We'll probably give some insulin to drive that potassium back into the cells to decrease that hyperkalemia. We may have to help the lungs with the hyperventilating, um, things like that. Acute and chronic metabolic alkalosis. This is your base bicarb excess. Metabolic alkalosis is characterized by high blood pH and high plasma bicarb concentration. Um, acute metabolic alkalosis refers to a rapid increase in blood bicarb levels causing a high blood pH due to a sudden loss of acid. An example of this is vomiting. While chronic metabolic alkalosis indicates a sustained elevation in bicarb levels over a longer period of time, often with the kidneys attempting to compensate by excreting more bicarb, but still resulting in an elevated blood pH. Both conditions are considered base bicarb excess, as the primary abnormality is an increase in bicarb ions in the blood. So, a common cause here is going to be severe vomiting or gastric suction. So, when you measure the gastric contents of a patient who is intubated and sedated, you need to put those gastric contents back in because you don't want to disturb that hydrochloric acid. A pyloric stenosis can cause this with a loss of acidic gastric fluid. Diuretic therapy, we could lose too much potassium, so thiazides and furosemide. And then an ACTH secretion with like hyperaldosteronism or Cushing's syndrome. The hypokalemia mechanisms, we're going to have nephrons that reabsorb potassium and secrete hydrogen into urine. The intracellular potassium is going to move out, allowing hydrogen to enter the cells for electroneutrality. And other causes could be excessive intake of alkali like antacids or long-term diuretic use. Villus adenoma and cystic fibrosis.
Stipulating agrees that she's committed.
Sorry about that. Our clinical manifestations here, symptoms are going to be related to hypocalcemia due to increased free calcium. So we're going to have tinglings in fingers and toes, dizziness, tetany. Neuromuscular symptoms are going to be primarily due to that ionized calcium depletion. Compensatory mechanisms, so the lungs are going to compensate by slowing that respiratory rate to increase that CO2 retention and the rising hydrogen. The kidneys are going to attempt to excrete bicarb and conserve hydrogen. We're going to see an increased hydrogen reabsorption, which leads to potassium excretion, which will equal hypokalemia. We're going to see a prominent U wave on an ECG and potential ventricular rhythm disturbances like PVCs because of that electrolyte imbalance, and then decreased GI motility and risk for paralytic illness. So, do you think you have to listen to bowel sounds on this patient? Yes, you do. So, assessment and diagnostic findings, we're going to have an ABG evaluation. So, pH is going to be greater than 7.45. The bicarb is going to be greater than 26, and increased PaCO2 due to hypoventilation. We're going to monitor urine chloride levels. It will help to identify the cause of the metabolic alkalosis, and it will differentiate between causes such as vomiting, diuretic therapy, and mineral low corticoid excess. If we have hypovolemia, our urine chloride is going to be less than 25. And if we have mineralocorticoid excess or alkali loading, our urine chloride is going to be greater than 40. So treatment goals for this condition is we're going to correct the underlying acid-base disorder. We're going to monitor intake and output due to potential volume depletion. We're going to administer normal saline to restore fluid volume, replace potassium with KCl if hypokalemic, use proton pump inhibitors to reduce gastric HCl production, and carbonic anhydrase inhibitors to enhance bicarb excretion in patients unable to tolerate rapid volume expansion. Then we move into acute and chronic respiratory acidosis. Respiratory acidosis is characterized by a pH of less than 7.35 and a PaCO2 of greater than 45. It can be classified as either acute or chronic. Acute or chronic respiratory acidosis is going to be the inadequate excretion of CO2 due to insufficient ventilation. It's going to lead to elevated plasma CO2 and increased carbonic acid levels, often results in that decreased PaCO2. PaO2. So for acute respiratory acidosis, this is going to occur in emergencies. Think pulmonary edema, foreign body aspiration, pneumothorax, sedative overdose, and non-emergent situations like severe pneumonia, acute respiratory distress syndrome. This is going to be common in patients with COPD during acute decompensation. And then for chronic respiratory acidosis, we're going to think COPD, obstructive sleep apnea, obesity. Patients will remain asymptomatic if PaCO2 does not exceed compensatory limits. So for clinical manifestations, we have acute respiratory acidosis. We're going to have an increased pulse, increased blood pressure, and increased respiratory rate. where patient's going to have possible confusion, disorientation, decreased consciousness. We're going to have an elevated PaCO2, which can lead to increased cerebral blood flow and ventricular fibrillation in anesthetized patients. And severe cases may result in increased intracranial pressure, papilledema, and hyperkalemia due to that hydrogen shifting into the cells and potassium moving into the bloodstream. For chronic respiratory acidosis, symptoms are going to develop only with that rapid increase in PaCO2. Patients with long-term COPD are going to adapt to high levels of CO2 without noticeable symptoms. I want to go back to acute respiratory acidosis. So this patient might present with confusion, disorientation, or decreased consciousness. A lot of times with these patients, we are going to want to give them some ventilatory support. We might use a type called BiPAP. BiPAP is never appropriate for a patient who has decreased consciousness. And here's a little guy that's going to tell you about metabolic alkalosis. But that doesn't fit there, so don't worry about it. I'll fix it. Our assessment and diagnostic findings. We're going to have a pH of 7.35, PaCO2 of greater than 45. Your bicarb levels are going to vary based on duration of acidosis. Prolonged compensation may normalize pH with bicarb retention. We're going to look at serum electrolytes, chest x-rays, drug screening, and ECG monitoring. Goals are going to be improved ventilation for both acute and chronic respiratory acidosis. Pharmacologic treatments are bronchodilators, antibiotics, thrombolytics, and anticoagulants. And then our supportive treatments, we can use pulmonary physiotherapy and nebulizer treatments to get that mucus out of the way. We're going to make sure that we increase hydration to maintain moist mucous membranes and low concentration of supplemental oxygen as needed. If we want to talk about mechanical ventilation, the PaCO2 should be reduced gradually to prevent rapid alkalosis, which can lead to seizures due to bicarb retention being slower than the hydrogen loss. Acute and chronic respiratory alkalosis, that's characterized by a pH of greater than 7.45 and a PaCO2 of less than 35. It can be classified as acute or chronic. Hyperventilation leads to excessive loss of CO2, decreasing plasma carbonic acid concentration. Some common causes are going to be that extreme anxiety with hyperventilation, hypoxemia, so low oxygen levels, salicylate intoxication, gram-negative sepsis, and inappropriate ventilator settings. Chronic I went way far. Hold on. Let me find where I am. Here we are. Chronic respiratory alkalosis results from chronic hypocapnia, so those low CO2 levels, and associated with chronic hepatic insufficiency and cerebral tumors causing sustained hyperventilation. So here we have a guy with our clinical manifestations. These are really, I think, really help understand what that patient is going to look like. So an elevated pH greater than 7.45 due to that low PaCO2, normal bicarb levels, and acute respiratory alkalosis, compensation in chronic respiratory alkalosis, those kidneys are going to lower that bicarb to near normal levels over time. Serum electrolytes, we want to monitor for decreased potassium due to that hydrogen being pulled from the cells. Decreased calcium levels may lead to carpal pedal spasms and tetany. Decreased phosphate levels are due to that increased cellular uptake. And then we want to rule out salicylate intoxication. Treatment's going to vary based on the underlying cause. For anxiety, we're going to have them do that paper bag method or that box breathing. Slowly breathe to allow CO2 accumulation. And then anti-anxiety medication may be prescribed. For other causes, we want to address the specific underlying issue leading to hyperventilation. Then we move into mixed acid-base disorders. Mixed acid-base disorders occur when a patient experiences two or more independent acid-base disorders. A normal pH alongside changes in PaCO2, plasma, bicarb indicates a mixed disorder. So simultaneously, you could have metabolic acidosis and respiratory acidosis, and this would lead to an excessive acid accumulation due to respiratory failure or cardiac arrest. So, other examples are sepsis. A patient with sepsis may initially have respiratory alkalosis, but then develop metabolic acidosis due to hypotension. COPD patients, an elderly patient with COPD may have respiratory acidosis, then develop metabolic alkalosis from diuretics. Diabetes, a patient with diabetes may develop DKA when their body doesn't have enough insulin. And then organ failure. A patient with renal, hepatic, or pulmonary failure will develop a mixed acid base disorder. So the pulmonary and renal systems typically compensate for each other to restore that normal pH. So we're either going to blow off the CO2 or we're going to excrete the bicarb. So the lungs will compensate for single acid base disorders, which is really what we're going to cover. The lungs are going to compensate for metabolic disorders by adjusting that CO2 excretion. Hypoventilation is going to increase that CO2. Hyperventilation is going to decrease that CO2. Kidneys are going to compensate for respiratory disorders by modifying that bicarb reabsorption and hydrogen secretion. So, with respiratory acidosis, we're going to see excess hydrogen excreted in the urine and bicarbs conserved. Respiratory alkalosis and increased renal exertion of bicarb and hydrogen retained. Metabolic acidosis, increased ventilation rate, kidneys retain bicarb. Metabolic alkalosis, decreased ventilation to conserve CO2, increasing PaCO2 and carbonic acid. The lungs are going to respond quickly within minutes, while renal compensation is slower, especially for respiratory imbalances. So it is not uncommon to have a respiratory acidosis or respiratory alkalosis, and then over a couple of days, it's going to change into metabolic because the respiratory compensation is very quick, and then it goes into metabolic. So blood gas analysis, I'm just going to talk about it here, but we're going to practice in class. Used to identify specific acid-base disturbances and the degree of compensation, typically based on the arterial blood samples. But you can also get mixed venous blood samples. Where I work, they do ABG and venous blood samples. The venous blood is a little bit easier to get, so that's why they like to use that. So we're gonna use ABGs to understand alveolar ventilation, oxygenation, and that acid-base balance. The serum electrolyte concentrations should also be assessed alongside the ABG data as they are affected by the acid-base imbalances. So that's why often in my setting, they're going to do a VBG, venous blood gas, because they're drawing the electrolytes at the same time. Here is a normal value table. Please understand the arterial blood normal values. That's what I would like you to use, and that's what I would like you to know during our class time. And then for comprehensive assessment for any of these disorders, we need to get a health history, physical exam. Maybe we can compare to previous blood gas results. Serum electrolyte levels are crucial. Because we can't fix this patient if we don't understand what the underlying cause is. And a lot of times their history is what will tell us what the underlying cause is. So we don't want to rely solely on isolated blood gas results because it can lead to misinterpretation. So if you think of like a COPDer, they might just live with an acid-base disturbance, but they're not symptomatic. So like with anything, if you're not symptomatic, don't treat it. The treatment is going to be, as always, correcting the underlying condition that resolves the acid-base disorders. So that being said, know those tables. Bring that table with you. I don't even care if you commit it to memory. You have a lot going on this week. But bring that table with you because it's going to be super helpful in trying to understand how to look at numbers and determine, is it respiratory or metabolic? Is it acidic or alkalotic? Because once we understand that and then we understand the presentation of the patient, we can treat the underlying cause. Okay, so I'll see you back here soon.